Thank you. I'm delighted to see such a turnout for this topic and for the presentations today. And it's a real delight to be back in Calgary. I was first in Calgary in 1950 when it was a very small, very uninteresting western cow town. If you had been in Laramie, Wyoming, you'd been in Calgary. And to see the explosive growth over the decades is remarkable and very pleasant. I have to start off with the standard disclaimer that I have no commercial interests and no relationships that could be construed as constituting a conflict of interest. Basically what that means is that I don't get any money from any pharmaceutical companies or from any private entities that are profit-making entities. Addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. It's a disease, it's chronic, it involves the pleasure circuitry, the motivation circuitry, the memory circuitry of the brain. I'm going to tell you a little bit about what we know about these circuits, and I'm going to try to answer the question, does our knowledge about addiction, our neurobiological knowledge about addiction, help to improve treatment for addiction? I think the answer is yes. We've got a long way to go, but the brain is hideously complex. 50% of the human genome codes for brain-specific chemicals and proteins. 50%, half of the engineering plan of a human being is devoted to this computer between our ears. That's how complex the brain is. And to think that we're going to understand it quickly or easily is a foolish idea. What one is struck with when one approaches the field of addiction is how stunningly few chemicals are addictive. If you go to chemical abstracts and you look at all known chemicals and all known congeners of all known chemicals, the human species knows about 30 million different chemicals. Only about 100 of them are addictive. Maybe I should move that number up to 200 since there's been an explosion in the last couple of years of so-called bath salts and cathinones and so-called synthetic cannabinoids. But even if I move that number from 100 to 200 or even to 300, that's still a stunningly small subset of 30 million compounds. So the question is, what's special about these 100 or 200, 300 chemicals that the other 30 million chemicals don't have? Well, first of all, they are rewarding. Animals self-administer them like humans do. The rank order of appetitiveness in animals parallels exactly the rank order of appetitiveness in humans. They activate the reward circuitry of the brain, and the degree of that activation correlates with degree of addictiveness. These chemicals act on the pleasure and reward circuits of the brain, and that's why people get high. The pleasure and reward circuitry of the brain, this is a rough sketch of a human brain side view. And you see the ventral tegmental area down there at the top of the brainstem. It projects, it sends wires, if you will, up to the nucleus accumbens, and from there further forward to other areas in the brain. And that link between the ventral tegmental area and the nucleus accumbens is the central circuitry for pleasure and reward. And that's what addictive drugs act on to get people high. This shows the side view of the human brain in a little bit more detail and shows you a little bit more of the projections of the wiring, going up to the prefrontal cortex and into the amygdala. And this shows a more close-up view. And you can see the pointer is not awfully good. Whoa, come on, Elliot, wake up. The pointer's not awfully good, so I'm going to have to verbally describe. You see the red circled area in the back. That's the ventral tegmental area, as you can see in the legend up at the top of the slide. And you see the blue area in the front of the brain. That's the nucleus accumbens. And that set of wiring, it's called the medial forebrain bundle, from the ventral tegmental area to the nucleus accumbens, as I said, the core central pleasure and reward circuit in the brain. How do we know this? We know this on the basis of electrical brain stimulation reward in both laboratory animals and in human subjects. If you surgically implant, that's me on the left, that's a postdoctoral fellow on the right. We are surgically implanting electrodes deep into a monkey's brain, into this reward and pleasure circuitry. And this is an X-ray of the animal after we've implanted the electrodes, and also there is a catheter that goes down into the anterior deep recess of the third ventricle, so that we can circumvent the blood-brain barrier and inject chemicals directly into the reward circuitry and the pleasure circuitry of the brain. Here's a monkey working a very complex task, which is absolutely at the outer limit of a monkey's cognitive and memory capacity. It's a delayed match-to-sample task, and the animal is doing this to get a 1/4 of 1 second train of electricity, very mild electricity, just sufficiently strong enough to activate the neurons, the nerve cells that are at the tip of the electrodes. And this animal is, that's his only reward. But that reward is so powerful that this animal will stick to this task and perform it, even though it is a very complex task for a rhesus monkey. Now, one can do electrical brain stimulation reward in laboratory rodents as well. Here you see a laboratory rat pressing a lever in its test chamber to activate a computerized system, which then activates a brain stimulator, which then sends a pulse of very mild electricity for a very brief period of time, 1/4 of 1 second, to the tip of the electrode implanted in the pleasure circuitry of the brain. So this animal is pressing that lever to get high. No chemicals involved, except the brain's own chemicals. It's the electricity that's activating the pleasure circuitry. In addiction, it's chemicals which activate the pleasure circuitry to get people high. Here you can see representative electrical brain stimulation response curves. On the bottom is the stimulation frequency, and on the left axis, the vertical axis, is the number of lever presses that a laboratory rat is willing to expend during a 30-second test bin of opportunity. And the green line is this particular animal's baseline. So at low levels of electrical intensity, the animal does not find it pleasurable, does not find it rewarding, does not find anything. So he doesn't press the lever. And then, as you increase the stimulation frequency, which means you're also increasing the charge at the tip of the electrode, the animal starts to find it pleasurable and starts to lever press. And then, of course, it asymptotes out at the very top, where the animal motorically cannot press the lever any faster than he's already doing. And here you can see the left shift, which is produced by an addictive substance. This is delta-9 tetrahydrocannabinol. It's the addictive constituent of cannabis. And that is a euphorogenic left shift. And this slide also illustrates another important thing. Notice that a low dose of delta-9 THC produces a pleasurable shift, a euphoric shift in the electrical brain stimulation reward curve. But when you increase the dose up to 5 milligrams per kilogram, you get a right shift. That's a dysphoric shift. And this is the laboratory animal homologue of what the drug user tells us. Because what the drug user tells us is low dose, good trip, high dose, bad trip. And this is, you're seeing it electrophysiologically here. It's real. What our patients tell us is real. They're not trying to put something over on us. Their descriptions are accurate in large measure. Early in recovery, you get lied to, but later on, the reports are often very accurate. We also know this on the basis of conditioned place preference to intracranial microinjection of rewarding drugs and self-administration of rewarding drugs directly into brain sites. Animals will self-administer the same drugs that human beings become addicted to, and they will self-administer them directly into the brain, but only into the reward circuitry of the brain. You can try hundreds, thousands of other places in the brain. The animals don't find it pleasurable, so they won't self-administer. Here's an animal set up with a micro injection system mounted on its head so that it can self-administer directly into the brain. The crucial reward neurotransmitter, which is to say, a neurotransmitter is a chemical which carries, nerve cells have gaps between them. And for about, in the human brain, about 96, 97% of the gaps are too wide for the electrical impulse to cross that gap. That gap is called a synapse. During the course of evolution, Mother Nature devised a plan that chemicals would carry the impulse across that gap to activate the next following nerve cell or brain cell. And we now know that there are somewhere around 400 or 500 different chemical neurotransmitters in the brain. That is to say, signaling molecules that carry impulses from one brain cell to another. The real total number is probably up in the low thousands. Dopamine is one of them. And dopamine is the critical. Dopamine does other things because dopamine is used in other circuits in the brain as well. Motor circuits, circuits involved in cognition and a whole bunch of other things, motivation, emotion. But one of the things that dopamine is used for is it is the chemical messenger, cell-to-cell messenger in the pleasure circuitry of the brain. And we know this on the basis of a lot of evidence. Virtually all addictive drugs are dopamine agonists. That means they mimic dopamine. Microinjections of dopamine agonists will produce conditioned place preference, which is to say the animal will go to the place where it gets the injection because it finds the injection pleasurable. I said intracranial self-administration. Also the effects of dopamine antagonists. These are drugs that block dopamine. They are dysphoric. And we also know on the basis of neurochemical analysis during drug self-administration using in vivo brain microdialysis. In vivo brain microdialysis is a technique for measuring in real time in awake behaving animals brain chemistry. Here's an animal that's set up to self-administer I can't remember if it's cocaine or heroin. I'll remember when I'm cued by the next couple of slides. At any rate, this is an animal that's set up to self-administer addictive drugs. And at the same time, the animal is implanted with a brain microdialysis probe to measure these neurotransmitters, specifically dopamine, in the reward circuitry at the same time. Here's a microdialysis probe to show you how very tiny these things are. Most of that you see in front of you is stainless steel, but at the very tip you see that translucent area. I'm going to try to get it with the pointer. Yeah. From here, from that point, my hand is a little shaky here. From this point to this point, that's 1/4 of 1 millimeter. So we are measuring neurotransmitters in a very small drainage area in the brain. That translucent membrane is a dialysis membrane, so that molecules can cross that membrane and then be carried out to a chemical analytical machine. Now, if one, here's an animal set up for microdialysis. This is a standard laboratory rat. Now, it was heroin self-administration. Okay, so here you're seeing a combination of heroin self-administration in a laboratory rat, and you're seeing several things. The vertical blue lines indicate where these vertical blue lines here, 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 here. That's where the animal voluntarily takes a hit of heroin. The yellow line is dopamine in the nucleus accumbens, that critical central point in the pleasure circuitry of the brain. So the animal gets put into the test chamber, and it immediately goes over to the lever. This is a trained animal. It immediately goes over to the lever that's wall-mounted in the test chamber and presses the lever a couple of times to get a loading dose of heroin. And that boosts the dopamine up into the pleasurable range. So this animal is high. This is the range where the animal is high because of the elevated levels of dopamine. Now notice what happens. The animal presses the lever, dopamine is released, the animal is feeling high here, so he doesn't press anymore, but then the dopamine begins to go down, and the animal says to himself, that nice feeling is going away, so I'm going to go and I'm going to hit the lever again. And he does, and it pushes the dopamine up. The animal is now high, the animal is satisfied, its heroin craving has been satisfied. And then as the dopamine trends down, the animal says to himself, aha, I better go over and get another hit. I want another hit. I want another hit. At these low points, the animal is craving the heroin, and that's why he goes over and voluntarily takes more heroin. You've seen this slide before. This is a rhesus monkey with electrodes implanted in the brain. And here's the animal working a difficult task. One can also interrupt the synthesis pathway for dopamine, and one finds that if one does that, one finds that if one gives a drug, this blocks the synthesis of dopamine. This is alpha-methylparatyrosine. It's an enzyme inhibitor. It's a tyrosine hydroxylase inhibitor. And if you administer this, after diffusion to the sites of action in the brain, the animal suddenly stops the electrical brain stimulation reward. You then you give the dopamine back, and the animal goes right back to the electrical stimulation. So we know that dopamine is the key player. That's not to say that there aren't other key players as well. There are. But dopamine is key. And we know that there are also proponent, opponent, and opponent brain reward processes in addiction. If the brain reward stimulating electrode is in the medial portion of the reward circuitry, what we see is that a single shot of morphine will elevate brain reward. In other words, the animal is high here. The animal is high. Then as the morphine wears off during the course of the day, because this is just a single administration of morphine, the high, as measured electrophysiologically directly in the brain, goes away. But now notice what happens from day to day to day to day. Now this is a laboratory rat, so the time processes are speeded up. In a human being, this would not be measured in days, this would be measured in months, and possibly in some people even in years. But look what happens. The high that's produced by the morphine diminishes with each successive administration of morphine. Now, we move the stimulating electrode into a slightly more lateral portion of the pleasure circuitry of the brain. We're moving it only about 1/3 of a millimeter, a very small distance. And look what happens. Now, the administration of morphine produces a dysphoric effect. And from day to day to day to day, the dysphoric effect intensifies. So the opiate addict soon finds himself or herself in a very bad situation. The high goes away. Tolerance develops to the high. But the low intensifies. And after a while, opiate users tell us, I'm no longer using the heroin or the oxycodone or whatever it is. I'm no longer using it to get high. I'm just using it to try to get straight. That's, I don't know what Calgary street language is. That's New York street language. We can also measure it neurochemically. This time not using in vivo brain microdialysis, but using something called voltammetric electrochemistry. Here you can see levels of dopamine in the more medial portions of the reward circuitry. Again, after administration of morphine. The animal is high because of these elevated dopamine levels. We move the recording electrode slightly laterally, and we find that the morphine produces a dysphoric effect. So we know this both electrophysiologically and we know it neurochemically. There are also drug withdrawal processes that are very important in addiction. Here you see, again, measured electrophysiologically using the electrical brain stimulation reward model in laboratory animals. Here you see, I've chosen to illustrate this with delta-9-THC, the psychoactive constituent in cannabis, marijuana. And here you see the animal is high here. In withdrawal, 24 hours later, the animal is very dysphoric. This is measured electrophysiologically in the brain. The animal is not, laboratory rat can't talk to us, but we're seeing this electrophysiologically. We're measuring it directly in the pleasure circuits of the brain. And does feeling crappy, feeling dysphoric in withdrawal drive the person to go back to using drugs? You bet. So withdrawal is a driver of going back and using, both in the acute sense, from day to day to day, and in the long-term sense. Because perversely, the withdrawal dysphoria gets worse as time progresses during recovery. That's one of the reasons that recovery is so damned hard. And that's one of the reasons that people who are in successful recovery have such immense strength of will. You know, you talk to some people, they say, oh, drug addicts and alcoholics, they just don't have strong will. I beg your pardon. To get over that incredible dysphoric state, which intensifies with the passage of time, requires immense strength of will. Drug addicts and alcoholics who are in successful recovery, I think, have the strongest willpower possible. This brings us to the concept of reward deficiency as a driving force in addiction. And we know that in addiction there is reward deficiency. Sometimes it is a predisposing factor, vulnerability factor for drug addiction and alcoholism, and sometimes it is the direct result of using for prolonged periods of time addictive drugs. Here on the top, you can see this is a cartoon, but it's based on electron microscopy. So it's based on electron microscope studies of these dopamine neurons in the reward circuitry of the brain. And up here on the top, you see a healthy neurofilamentary transport system for tyrosine hydroxylase in these dopaminergic pleasure neurons, and healthy levels of dopamine, and then a bunch of post-receptor transduction cascades. Here, you see the pathological decrease in dopamine in animals that are either born with a genetic predisposition for drug addiction, for drug liking and drug taking, or animals that have been made drug liking and drug taking by a long history of being administered addictive drugs. In either case, whether you cause the vulnerability genetically or you cause it by drug experience, repeated administration of drug, you see the same pathological decrease in dopamine in the brain reward circuitry. Is it possible then that some substance abusers have a defect in their ability to capture reward and pleasure from everyday experience? The answer is yes. And this brings us to the hijacked brain hypothesis. Addictive drugs act on the same brain reward circuits and mechanisms as natural biologically essential rewards do. And addictive drugs derive much of their addictive power by activating these circuits more powerfully than natural biologically essential rewards. And there is solid experimental evidence for this. This shows you the risk of addiction, and it has absolutely nothing to do with whether a drug is legal or illegal. Nicotine, look at the addictive risk for nicotine. Nicotine is the most addictive substance that we know of, followed by heroin, and then cocaine, and then alcohol, and then cannabis, and even below cannabis would be benzodiazepines and barbiturates. Very low risk of addiction, but nicotine and heroin, very high risk of addiction. The contributions to the disease of addiction are 50% genetic and 50% environmental. And I'm going to illustrate that for you with some slides that show neuroimaging of the brain. But I want to first tell you about vulnerability factors for the disease of addiction. lack of homeostatic reward regulation, novelty-seeking, sensation-seeking, impulsivity, antisocial conduct disorder, especially in adolescence, depression, ADHD, and reward deficiency. Now, here's an interesting experiment. What you're looking at is neuroimaging in the brain of rhesus monkeys. Now, these are rhesus monkeys that are in a social troop of rhesus monkeys, either individually housed or socially housed. And here you can see, this is the brain. This is using positron emission tomography neuroimaging. Here you see the brain of the alpha male, the dominant animal, in the troop. Very robustly healthy levels of dopamine. And here you see the poor guy at the bottom of the pecking order, the guy who's being beat up on all the time, having his food stolen from him. This guy feels very good in his own skin. He feels very good about himself. And this guy doesn't feel very good about himself. He's constantly, his life is hell. He's constantly being beat up. His food is constantly being stolen from him. And if you then individually house the animals, you see a decrease in the amount of dopamine, but still the dominance or status hierarchy maintains itself. Now, this alpha male over here takes significantly more cocaine, if given the opportunity to do so, than the submissive animal. And there is a hierarchy of willingness to self-administer cocaine. Up here, this guy takes very little. Down here, this guy takes a lot. Now, if we do something, if we alter the social hierarchy, if we introduce a new alpha male into the group, a younger, stronger alpha male, who displaces this guy and pushes this guy down a couple of rungs on the status hierarchy, what happens is that the levels of dopamine decrease in the brain, and this animal, who formerly was pretty resistant to self-administering cocaine, now becomes more likely to more willing, more wanting of cocaine, and more, and actually, as measured, self-administers more cocaine. So we have changed the neurobiology. We've changed the brain by simply altering the social status hierarchy in the group of animals. Now, same thing here well, it's not the same thing. This is how the administration of drugs can also alter the amount of dopamine that's in the nucleus accumbens in the brain, with consequent effects on willingness to self-administer drug. Here on the left, this animal has robustly healthy levels of dopamine in the pleasure circuitry of the brain. Here is a cage mate, a litter mate, that was administered amphetamine for a prolonged period of time. And you can see the deficiency. There is a pathological decrease of dopamine in this guy's brain as opposed to this guy's brain. And same thing happens in rhesus monkeys. This is a cocaine-naive rhesus monkey, very healthy levels of dopamine in the pleasure circuits of the brain. And over here, this animal is a cocaine-experienced monkey after 227 days of abstinence. These deficiencies in the brain are slow to recover. And that's one of the reasons that becoming long-term abstinent is difficult. These brain levels of dopamine will eventually recover, but it's not easy. We can also play with psychological traits. Impulsivity. One can breed animals to be high impulsive or low impulsive. And what you see is in the impulsive animals, which are here on the right, you see a pathological deficiency of dopamine in the pleasure circuits of the brain. Here's a normal rat brain, and here's a rat brain of a rat that is impulsive, has the psychological trait of impulsivity. And if we look at how much is this cocaine? Yes, this is cocaine self-administration. The impulsive rats are the black dots. These guys will self-administer much more cocaine or heroin or alcohol or amphetamine than the non-impulsive rats. So, you see, addiction really epitomizes the bio-psycho-social, and I haven't shown it to you, but I would also add spiritual aspect of the disease. Because we've done social manipulations, we've done psychological manipulations, they have changed the brain and thus changed the animal's willingness to go out and self-administer addictive drugs. There is a progression of drug-seeking behavior from being reward-driven to being habit-driven. After a while, many drug addicts will say, I don't know why I'm shooting up, because I'm no longer getting high. It's just kind of an ingrained habit. And in laboratory animals, we know that that's true. There is a progression from being reward-driven to being habit-driven. And we even know, this is merely a statement by some very brilliant researchers at the University of Cambridge in the UK. We know the anatomy of this progression from reward-driven drug seeking to habit-driven drug seeking. The reward-driven drug seeking, when the animal or the human being first starts out, is this circuitry here, this loop circuitry from the ventral tegmental area to the nucleus accumbens, over here on the left, the red. So these are the circuits that subserve the reward-driven drug-seeking behavior and drug-taking behavior. And as the disease of addiction progresses from being reward-driven to being habit-driven, the locus of control of the behavior in the brain moves laterally from these medial circuits here along the midline in the brain over to these more laterally lying circuits, first the yellow and then the green and then the blue. And as time elapses, in addiction, these circuits come to dominate the animal's behavior and the human being's behavior. And the drug-taking behavior is no longer reward-driven, it's habit-driven. It's no longer pleasure-driven, it's habit-driven. An important point to make is that addiction is not physical dependence. There are a lot of drugs that produce physical dependence that are not addicting. High blood pressure runs in my mother's family. I was unfortunate enough to get the genes. So starting when I was quite young, my primary care provider said to me, Elliot, you've got marginally high blood pressure for your age. There will come a time when I'm going to have to put you on some antihypertensive medications to keep your blood pressure down and to dramatically lower your risk of suffering a heart attack or a stroke. And I said, whenever you feel the time has come, do it, because I sure as hell don't want to have a heart attack or a stroke. Now, so I am on, and have been for the last 25 years, I am on antihypertensive medication, blood pressure lowering medication. I'm physically addicted to those medications. I will go into significant withdrawal if those medications are abruptly stopped. But I'm not addicted to my blood pressure lowering medications. I get no pleasure from them. I get no reward from them. I take them as a prudent preventative health measure. And some drugs produce addiction without much physical dependence. Animals will take addicting drugs in the absence of physical dependence. Pain significantly reduces addictive liability. And that's very counterintuitive because some addictive drugs, the opiates, are really excellent analgesics, as anyone who has had surgery and then had to take morphine post-surgically for a few days or a few weeks knows. And the brain sites of addiction differ from the brain sites that mediate physical dependence. The real problem in addiction medicine is relapse. Everyone knows that. Everyone knows that. The 19th century American humorist Mark Twain knew it. He said once, stopping smoking is very easy. I've done it hundreds of times. Which means that he had relapsed hundreds of times. And we know, ever since the 1930s, and the incredibly insightful work of Alcoholics Anonymous, that there are three major triggers to relapse. One is re-exposure to drug, and it doesn't have to be the same drug that the addict was self-administering. The second is stress. That's a trigger to relapse. And it can be mild stress. Just low-level day-to-day hassle is a good trigger to relapse. It doesn't have to be horrifically high levels of stress. And re-exposure to the environmental cues that were previously associated with drinking and drugging. What Alcoholics Anonymous says, you must avoid the people, places, and things that were previously associated with your drinking habit, because those things will trigger you to go back to drinking. Now, we've come a long way since the 1930s. We know that all of this is correct, but now we know what the circuits are. Here is the circuit, if I can get this pointer to work. Here is the circuit going from the ventral tegmental area up to the nucleus accumbens. This circuit, which uses dopamine as its neurotransmitter, that's the drug-triggered relapse circuit. There are two stress-triggered relapse circuits in the brain. One originates in the lateral tegmental nucleus of the brainstem, uses noradrenaline or norepinephrine as its neurotransmitter, and sends projections, wires, if you will, to the hypothalamus, the bed nucleus of the stria terminalis, the nucleus accumbens, and the amygdala. There is a second stress-triggered, I mentioned the bed nucleus of the stria terminalis. There is a second stress-triggered relapse circuit in the brain. Whoops, go back. There's a second stress-triggered relapse circuit in the brain. It starts in the central nucleus of the amygdala and projects down to the bed nucleus of the stria terminalis, and it uses CRF, corticotropin-releasing factor, as its neurotransmitter. And there are two environmental cue or context-triggered relapse circuits in the brain. One originates in the ventral hippocampus, particularly the subiculum, and projects down to the nucleus accumbens. The other originates in the basolateral complex of the amygdala, projects down to the nucleus accumbens. Both of those cue or context-triggered circuits use glutamate as neurotransmitter. So, for example, there are implications. There are people who are working on anti-CRF medications as possible pharmacological aids for stress-triggered relapse. And there are people who are working on glutamate, metabotropic glutamate antagonists as possible pharmacological aids for environmental cue or context-triggered relapse. Vulnerability to relapse increases over time. I've intimated that before, and it's one of the reasons why maintaining sobriety is a difficult process, and one has to continue to work at it constantly. So there are some important take-home distinctions, important messages. The drug-induced high or hit or blast is due to activation of the pleasure and reward circuit that runs from the ventral tegmental area to the nucleus accumbens. There are 3 separate craving and relapse circuits in the brain. We now know their neuroanatomy and their neurochemistry, and there is hope that at some time in the future we may have some pharmacological interventions that will help patients in recovery. Physical dependence and withdrawal are different from addiction, and they're mediated by different places in the brain. And analgesia is separate from all of those other things and mediated by other areas in the brain. Another crucial take-home message is that one cannot produce addiction by medically appropriate, and I stress, medically appropriate long-term treatment of pain with opiates, except in patients with a pre-existing vulnerability to addiction. I won't go through all the evidence. There's a lot of evidence for that statement that I just made. But what all of that evidence combines to tell us is what the World Health Organization has put out in its guidelines for the treatment of chronic pain. When opioids are used, even at heroic doses, in the appropriate, and I emphasize, appropriate medical control of chronic pain, addiction and drug abuse are not a major concern. That's the World Health Organization. What about memory? I'm coming to the end of my time. I'm coming to the end of my talk. We know that addiction is a chronic relapsing disorder, and it is characterized by maladaptive drug-associated memories, and it can be considered as a disorder of aberrant learning and aberrant stimulus-response habits and associations. And sometimes memory is very directly involved in addiction, as in the phenomenon of chasing the wonderful first high, but never or very rarely ever achieving it again. The circuits that are involved in the memory aspects of addiction are in the hippocampus and in the amygdala. What about executive functions? Bad decision-making is also part of addiction. So there are parts of the brain where decision-making takes place. It's given the fancy name of executive function by neuropsychologists and neuroscientists. These executive functions are located in the frontal cortex, perhaps an area called the insular cortex, and the anterior cingulate cortex. There are some pharmacotherapies for drug addiction. Some of them are agonist therapies, some of them are antagonist therapies. Some of them work for some patients. And when something works in a given patient, you say, thank God, and your life is easier in helping that patient achieve sobriety and abstinence. There are some currently promising medication development strategies that I list here, and it would take like hours for me to go into why these are promising medication development strategies, but they are. The future of treatment addiction, I firmly believe, will involve, I'm not going to say that this is going to be the totality of the treatment of addiction in the future. No, that's bizarre. We will continue to use all of the modalities, the biopsychosocial, spiritual interventions that we currently use, because they work. But we will also be able to add neurobiology mechanism-based, hypothesis-driven medication development for assisting people who are having a hard time achieving and maintaining sobriety and abstinence. And I also believe firmly that another aspect of the future of addiction treatment is predicting vulnerability to addiction by neuroimaging or perhaps by whole genome scanning to detect vulnerability genes. And if we can intervene before people get the disease, and we can counsel them and warn them that they have this vulnerability, then we would be doing the same thing that we do in diabetes. If we know that a patient has a vulnerability to diabetes, we intervene very early, pre-adolescence, and we counsel that patient and that patient's parents, and we say, unfortunately, this child has a vulnerability to a very nasty disease, diabetes. Now, if this patient adopts an appropriate lifestyle and follows these specific guidelines, you can have a perfectly normal life and a normal lifespan. If the patient does not follow these guidelines, then you're looking at diabetic neuropathy and amputation of the legs. You're looking at diabetic retinopathy and blindness. You're looking at a life that's going down the toilet. So one can approach addiction as one approaches diabetes. They're both diseases. It's no one's fault that they get the vulnerability for diabetes. It's no one's fault that they get the vulnerability for addiction. But they can be considered to be parallel diseases in the way we approach them. Bottom line, thank you. I have to acknowledge people in my own laboratory in the intramural research program of the National Institute on Drug Abuse. I have to acknowledge people in my laboratory at the Albert Einstein College of Medicine in New York City, where I was on faculty for 33 years before being recruited to the National Institutes of Health, colleagues at St. John's University, at the Beijing Institute of Pharmacology and Toxicology, at GlaxoSmithKline Pharmaceuticals, at Mega Pharmaceuticals in Hungary, and the University of Massachusetts at Lowell. Research support, at present time, major research support for my work is coming from the intramural research program of the National Institute on Drug Abuse and the Beijing Institute of Pharmacology and Toxicology of the People's Republic of China. But other support in the past has come from Norway, from the Norwegian Research Council, from Canada, from NSERC, where the hell is it? Yeah, there it is. The Natural Sciences and Engineering Research Council of Canada, from the New York State Office of Alcohol and Substance Abuse Services, and the New York State Office of Mental Health, and some private foundations. And with that, I leave you with this last picture. It shows my research laboratory at the U.S. National Institutes of Health. And take a careful look at the faces. Aside from the white guy here and the black gal there, every other face is Chinese. China is the looming scientific and technological and, I believe, economic and political giant that is probably going to dominate coming centuries. Thank you very much.